Hi everyone, this is your nurse practitioner board certification review courses. Again, my name is Dr. Famous Favor, and I'll be taking you in extrapyramidal side effects. So, extrapyramidal side effects is a very interesting topic and is known to be more prevalent with the first generation antipsychotic. So, I will abbreviate it as FGA. This is due to their strong dopamine receptor blockage, especially, we have these dopamine pathways, but that will be in another video. But for the purpose of this video, it will just be extrapyramidal side effects. So in the nigrostriatal pathway, but we still have the other pathways, but I'll just be talking about this pathway. So it can also be seen in the second generation, but the second generation is mostly due to the ones that have a higher dopamine binding affinity, like the risperidone and the paliperidone. We have the antipsychotic classification table, as you can see, just for more emphasis. So we have the three generations or three classification, however you want to talk about it. The fourth generation is known as the typical antipsychotic. So it's broken down into high potency, mild potency, and low potency. So for the emphasis for the exam, what are the things you have to monitor? At least you have to remember haloperidol, remember chlorpromazine, and tioridazine. You can still know the other medication, but for the exam, I'm more focusing on that. So the haloperidol and the chlorpromazine and the tioridazine. So I always remember it as HCT, haloperidol, chlorpromazine, tioridazine. So you see that this first generation, they have a high risk of EPS risk. So we're still going to come to EPS, and they have a higher the sedation, which is mostly the low potency, higher sedation, orthostatic hypotension, QT prolongation, and but we're still going to come to that. Then we have the second generation where you have your Zyprexa, Seroquel, Risperdal. The list of the medications are there. Zyprexa, Seroquel, Risperdal. So for this second generation, you are going to monitor more of metabolic syndrome. They have a lower EPS. When I say EPS, remember is extrapyramidal symptom. So they have a lower risk of EPS but higher chances of metabolic syndrome. What are those metabolic syndrome? You monitor patient for weight gain, hyperlipidemia, diabetes. Also for this second generation atypical, we have medications like this olanzapine, the clozapine, and you monitor more for metabolic syndrome. Then we have the QT prolongation, for the quietapine. Okay. Then the Resperdon. Then you have the Resperdon. You monitor hyper prolactinemia. Then you have clozapine, you monitor agronocytosis. So I'm not here to talk about antipsychotic, but just a refresher for you to remember the classification: first generation, second generation, third generation. Then the third generation is where you have your Abilify. So this one, the dopamine partial agonism, they stabilizes the dopamine level. So they are going to have more lower EPS and lower metabolic risk. But please pay attention, follow us for more videos. You find that we are not here about the antipsychotic, but this is just a more clarification table. First generation, second generation, third generation. What are you monitoring for the first generation? More high risk of EPS, extrapyramidal symptom, and also neuroleptic malignant syndrome, but we are not talking about that today. Then we have the second generation where you have more metabolic syndrome like olanzapine. Some people remember olanzapine, O as in obesity. Olanzapine, you monitor weight gain, metabolic syndrome. Then for QT prolongation, quietapine, then risperidone, hyperprolactinemia, then clozapine. Closely monitor agronocytosis. So clozapine, agronocytosis. Then we have the first symptom of EPS, acute dystonia. The most important thing is not to know when these symptoms occur. Like some people say, or usually occur days when this patient is on this medication. It's not the days is not the most important thing, but for you to know what happens. So this acute dystonia patient is going to present with a lot of muscle spasm of the face. So think about muscle spasm, something that has to do with the neck. They will have a lot of pain, facial grimacing, and also patient is going to have a tongue spasm. And sometimes they're going to have on rare presentation oculic crisis. Okay, and they may also have a risk of permanent injury. But what happened here in oculogeric crisis? Patient is going to have a prolonged involuntary upward deviation of the eyes. So they can ask you questions on that about the ocularic crisis. So, but in acute dystonia, so always remember that there's a muscle spasm of the face, the tongue, especially the back and the neck of the muscles. So patient may have a facial grimacing, and it always has to do with the muscle spasm. So it might be confused with what agitation, but always remember there is a involuntary muscle spasm and contraction. So that is your dystonia. Then the next one is akathisia. So I always remember Akathisia, if you remember, is mostly involuntary. Patient appears to be restless, so it can be confused with anxiety. So I use this A in the middle to remember anxiety. Patient have like more of symptom of anxiety. Patient, so think about somebody that have anxiety. Patient is pacing, patient is restless, patient is has the inability to remain still, or the feet is constantly in motion. And so for these patients, we are going to treat them first with beta blocker before we give them anticholinergic cogentin, then benzodiazepine. But always remember the first line, beta blocker, to calm the patient down. So akathisia has to do with A in the middle, which is anxiety. It looks like patient has a symptom of anxiety, restlessness, difficulty standing still, constantly in emotion. So that is your akathisia. Then we have akinesia. Akinesia has to do with more of I use the N in the middle to remember napping, like somebody taking nap. So when somebody is taking nap, it looks like the person is lazy, person is tired. So these people, they have initiating motion, difficulty initiating motion, absence of movement. Um, you see that patient have a feeling of lack of motivation to do things. So the akathisia, I remember it with anxiety. Akinesia, I use this N to remember like patients has signs of like napping, like when somebody is taking a nap, the person is lazy, the person feels weak, there's no motivation, there's no movement. So that is akinesia. And the treatment is always confused with a patient being lazy, patient has no interest in doing things, and it can be confused with the negative symptoms. So the treatment here is also cogentin benzotropine. Then we have the next one, which is your pseudo Parkinsonism. So the pseudo Parkinsonism is like false Parkinson symptom. So patient appears to have the symptoms of Parkinsonism. So you are going to see muscle rigidity, shuffling gait, motor slowing, mask-like facial expression, pure rolling tremor. So what is this pure rolling tremor? This is a tremor at rest. So tremor at rest is not as a result of activity, is at rest. So that is your pure rolling tremor. And also patients may have like mask-like expression, like they appear like they are crying, mask-like expression, resting tremor, pure rolling tremor, they are something. Then we have the tardive dyskinesia. So what is this tardive dyskinesia? Is abnormal movement of the lip. So you can see things like protrusion of rolling of the tongue, lip smacking. So when you are asked about lip smacking or chewing motion, facial dyskinesia. So all this has to do with tardive dyskinesia. So you see the involuntary abnormal muscle movement of the mouth, of the tongue, of the face, okay? And it can be irreversible. So this medication, Reglan, it can increase the risk of tardive dyskinesia. So very, very important to note. Then this is a mnemonics to help you to remember. The acronym is DAAPT. So what is this DAAPT? D, dystonia. So that is the sudden involuntary muscle contraction. Remember the oncologic crisis. So what is the treatment here? So first of all, pay attention and see that dystonia, akathisia, akinesia, and this and the pseudo Parkinsonism. So when you talk about this, okay, dystonia, you see that the treatment is anticholinergic. Just a simple way to remember. Akinesia, you also see that the treatment is also anticholinergic. Pseudo Parkinsonism, the treatment is also anticholinergic. The only one that the treatment is not anticholinergic, tardive dyskinesia. So that is the one we use the VANT VMAT2 inhibitors and Ingresia. So you can read that up too. But always remember DAPT, D for dystonia, A for akathisia, and I said A in the middle remembers anxiety, signs of restlessness. Patient cannot sit still. Patient is pacing around. So you give them beta blocker to calm them down, or benzodiazepine. Then the akinesia, N in the middle is a sign of napping. When somebody is taking a nap, the person appears to be tired, person appears to be tired or do not want to initiate movement, there's no motivation in initiating movement. Then we have the pseudo Parkinsonism. The pseudo Parkinsonism is the, like they have the signs or it mimics Parkinson disease. Then you have the tardive dyskinesia where you have the lip smacking, tongue protrusion. So remember the acronym DAPT. Then this is the summary of everything we went through. Acute dystonia, sudden muscle spasm. So look at it. You can use D, dramatic twisting. It has to do with the muscle spasm, muscle spasm. So the treatment is benzotropin. Okay. Then akathisia, restlessness, pacing, inability to stay still. Remember it with anxiety, signs of anxiety. So we said that the first line of treatment is your propranolol beta blocker, and they give them benzodiazepine. Then the third is anticholinergic. Okay. Then akinesia, N in the middle, napping. When somebody after taking nap, there is a loss of movement, difficulty initiating movement, lack of motivation, lack of energy, absence of motion. So this is still anticholinergic, benzotropin. So if you look at all that I said, you see that benzotropin is in the acute dystonia, benzotropin is in echinacea, benzotropin is in pseudoparkinsonism. Then the last one is tardive dyskinesia. So tardive dyskinesia, they have involuntary abnormal movement. So the treatment is your VMAT2 inhibitor, Ingresia. Okay, but remember, we don't give them cogentin. Do not give cogentin in tardive dyskinesia because it's going to worsen the symptom. And this is the references. Thank you for listening. Follow us for more videos.